All right, it's 12 o'clock, so we're going to go ahead and get started. This is actually my favorite medical grand rounds of the year, of course, because I have my own biases. But this is our 33rd annual Meneely-George Lectureship. It's always worth talking a little bit about the history, very briefly to give Dr. Kraft as much time as possible. But Dr. Meneely came here to help form this medical school. He's originally from Long Island, was educated at Princeton and University of Rochester, and he was an early physiologist who worked with radioisotopes to really understand cardiac and pulmonary physiology. He was passed over for promotion at Vanderbilt and was irritated with them, so he was transiently at Northwestern and MD Anderson, and he came here to help us build the school. As part of that, he recruited Dr. George to come and be our founding section chief. Dr. George himself was the 2000 Dr. Meneely lecturer, but he was added to the title of this lectureship by Dr. Payne back in 2010 to recognize his remarkable contributions to our division, our department, and to our institution. Dr. George was originally from Louisiana and did much of his medical training here, and he came here in 1971 to build the division. He was able to build a clinical and research division that was pretty impressive with a special expertise in pleural disease. For those of you who recognize Light's criteria, Dr. Light passed through here for a while and had worked with Dr. George. He's a past president of the American College of Chest Physicians and the like, and really made this lectureship possible by his early work on the Meneely lectureship, where he invited, as the president of ACCP, he knew lots of people and invited lots of luminaries in the field. So when I email people like Dr. Kraft, I get to say, hey, all these other people have come before you. Wouldn't you like to come to Shreveport? And fortunately, it tends to work out because they are remarkably kind individuals. Each year, we sit down and talk about who should we get. We're always looking for people who have made extraordinary contributions to pulmonary critical care, allergy, or sleep medicine. And I think this year we've really hit a home run with Dr. Kraft. She's now the chair of the Department of Medicine and the Robert and Irene Flinn Professor of Medicine and Deputy Director of the Asthma and Airways Disease Center at the University of Arizona. Her career has moved through numerous different institutions and ultimately is one of the world's leading experts in the immunobiology of asthma. As you look through her CV, it goes on, and I can't do justice to it in the minute or so that I'm going to continue to talk. She has more than 150 publications, uninterrupted federal funding, et cetera, et cetera. What's remarkable as I look at it is that she's also had a dedication to teaching, has mentored people without stop throughout her entire career, even when she's as busy as she has been. Additionally, what I really like about this is actually getting to meet the Meneely-George speakers, because without exceptions, they have all been remarkable individuals who actually are also remarkable human beings. I'm amazed. She actually has a black belt in karate, because in raising her son as a family activity, they decided to go and do this. I always think of these luminaries as being people who are like 100% into their profession, but as we talked, she's done Disney cruise vacations and black belts in karate and stuff like that. And so she really is, I think, exemplifies what all academic physicians should want to be. So with that, I will let her tell us about the immunobiology of asthma.
Thank you. Thank you very much. That was a really nice introduction. I wish my mother were here to hear that. Anyhow, thank you so much. Can everybody hear me okay? All right. It's really an honor to be here. I saw the other names that have been listed for this lectureship, and I'm very honored. Thank you so much for the invitation. It's been a wonderful visit. We had a lovely dinner last night. I got to meet Dr. George and learn a lot about the history of the program and reconnect with some people I have known, and also meet some new folks. And then this morning I had a great time meeting with the fellows, allergy and pulmonary fellows, just to hear about what they're doing, what career decisions they're making, and I feel like it's an exciting time for them. Their whole lives are ahead of them, and sort of what roadblocks, what challenges, and that's one of the areas I very much enjoy. As I mentioned last night, I feel like it's our duty now to think about that next generation. We have to train our replacements. So anyway, I'm happy today to come and talk about asthma and tell you what's been happening in the field. It's really gone crazy. And so who knew back when I got into this arena many years ago? So just a few issues on disclosures where I have some research funds paid to the university. I do a little consulting. I don't have a heck of a lot of time for that. Usually if it ends up being trials, that's one of my motivations for doing the consulting, so that works out nice if I can then be a PI of clinical trials, and then I've edited a book. All right, so hopefully what I'd like to talk about today in the time I have with you is I'll briefly discuss some advances in asthma pathobiology. That's really a whole lecture in and of itself. But I'd like to tell you a little bit about some things we're doing in my laboratory, because I have a bench laboratory and we do clinical trials as well. So I consider myself a translational researcher. And then what's very exciting is there's a lot of ways to treat asthma now that we weren't able to really do back in many years ago. And so the field's changed a lot. I'd love to tell you about how we can really deliver much more personalized or precision medicine in 2019, really in ways that we weren't able to. And I think other fields are certainly following suit. So I feel like we are a little ahead of the game in that arena. So I'm going to start with a case. This is a former patient of mine when I was at Duke, 38-year-old female with severe persistent asthma on chronic oral steroid therapy, presented with increasing shortness of breath and wheezing, diagnosed at age 7, had at least one hospitalization per year since her diagnosis, in addition to 2 to 3 exacerbations per year, treated as an outpatient. She's been intubated once, been on oral corticosteroids intermittently, and has many comorbid conditions that you would think would go along with this presentation: reflux, allergic rhinitis, she has nasal polyps, depression, and osteopenia. At the time she presented, she was having daily shortness of breath with really limited activity. She was using her rescue inhalers, albuterol primarily, and she also had a nebulizer of albuterol and ipratropium or Duoneb 4 to 5 times a day, which is absolutely more than we want our patients to be using, but she really did need it. And I do believe she was adherent with her regimen. And that's in any management of chronic disease, that's a very tough challenge to determine adherence in an honest, non-confrontational way. But I do think, in fact, she was adherent with her regimen. So her medical problem list is what you might expect, pretty much what I had mentioned. And she has aspirin sensitivity and nasal polyps and asthma. So she has Samter's triad. And the reason that's a good thing to identify, obviously nasal polyps are important to identify, these people tend to be very big producers of what we call leukotrienes. And if you've heard of the drug singular montelukast, Xyluton or Zyflo, those are great medication options for these patients. And speaking of meds, this is her long list. At the time she presented, she actually responded better to Medrol versus prednisone. Some patients do. So the trial of outpatient therapy had ensued, and she did not succeed, so came to the emergency department, was on high-dose fluticasone, salmeterol, or Advair, and then the montelukast, as I mentioned, and many other medications that you see there. She's married with 3 children, has 2 dogs, outside cats, office work with no exposure, and she was a never smoker, had a significant family history, mother with asthma and atopic dermatitis. On exam, she had prolonged expiration with moderate air movement, diffuse expiratory wheezing. And biomarkers, which I'm going to talk about a little bit more, at the time she had peripheral eosinophils of about 350 per microliter, and her exhale nitric oxide, which is a measure of uncaptured inflammation, was 40 parts per billion, so that's elevated. Normally it would be less than 20, so that suggested that she's got some untreated inflammation that we could address. And this is her x-ray, and I think what you can appreciate, she has some flattened diaphragms, heart size was normal, really no focal infiltrates, maybe some, a suggestion of some increased markings bilaterally, but nothing focal. And this is a pretty typical chest x-ray for a patient having an asthma exacerbation. We were able to get pulmonary function tests, and so this is the forced vital capacity. So this is how much you can exhale in 6 seconds, and that was 2.4 liters per predicted. Based on her age, height, and gender is 3 liters, so 78% predicted, not bad. Anything around 80% is normal. However, if we look at what she was able to exhale in 1 second, because in asthma, it's an expiratory flow limitation, tough to get the air out. She's around 48%. And in fact, her ratio of FEV1 to FVC, normally that should be about 86 for her. It's usually around 80. You should be able to get about 80% of your exhaled breath out in the first second. Clearly that was not the case. So severe airflow limitation. So what is asthma? Well, it's a chronic disease, a syndrome, characterized by wheezing, shortness of breath, and cough. And really the issue is this reversible airflow obstruction. So in many cases, especially in our mild to moderate asthma, which we have great medications these days, we can ask our patients to use albuterol before and after pulmonary function, and we can normalize their pulmonary function if it's not normal already. So that's the reversibility piece. Now you can see that in COPD sometimes as well, in bronchiectasis, but it is a characteristic of asthma. As the asthma gets more severe, there's less and less of that reversibility, and that actually can be a challenge, and so we'll address that. Then this concept of bronchial hyperresponsiveness, what is that? I think of it as this airway twitchiness. So if anyone in this room has asthma or has family members with asthma, you walk out on a cold day like this morning, take a big breath, and you could start to feel chest tightness, maybe even wheezing. That's that airway twitchiness. Or you go out on one of these beautiful spring days, I'm sure you have here in Shreveport, where everything's blooming. Same issue if you've got allergies. And so that's a unique characteristic of asthma. And one of the reasons this hyperresponsiveness exists is airway inflammation is one of the drivers. And that's been a real focus of research really over the last couple of decades. And so this is just a little cartoon that just shows why asthma makes it hard to breathe. There's a lot of changes that go on in the airway. The airways are really inflamed, so consider redness and swelling. So they're very inflamed. The smooth muscle, there's too much of it, undergoes hypertrophy and hyperplasia. There's a lot of mucus. You might think about mucus more in the COPD arena. Actually, in asthma, it's a real problem, especially in those small airways, which can become quite obstructed. And that's actually why patients die with the disease, is they can't ventilate due to this inspissated mucus. And so you can see how that would cause this airway narrowing, certainly compared to the normal state. So when I think about pathophys in asthma, huge explosion in our understanding of the immunology. And what's been exciting about that is that's translated to treatments. So we now have therapies based on our understanding of the immunology, and I'll talk a little bit about that later. I'm going to talk a bit about phenotypes, which are essentially collections of clinical characteristics that suggest a mechanism. So how can we use that in clinical practice? I'm going to give you just a little example of some things we're doing in the lab I'm kind of excited about, and that talk about the innate immune system. That is actually the host response to insults. Adaptive is more the allergic inflammation. Innate is more the host response. And then, of course, like I mentioned, we see a lot of airway structural changes in the airway. And how significant is that to a patient, and can we reverse that? So these are some of the areas of change or some evolution of asthma pathobiology. So just given that I don't have that much time with you, I'll just focus on one and tell you about a little bit about what my dear friend and collaborator Julie Ledford and I are doing in the area of surfactant protein A. So why would I bring that up? So you might think about surfactant as something that babies receive if they're born early, and because it reduces surface tension in the lung. So that's the lipid part of surfactant. We're looking at the protein, which has known host defense properties, and we are working on linking it to asthma and developing a new therapeutic that I'd like to tell you about. And Julie and I have been working together for a long time. We worked together at Duke and moved to Arizona back in 2014, and so we're moving this along. And so basically, the innate or host defense function, of course, is critical to preventing asthma attacks. SPA, surfactant protein A, is a key innate immune modulator produced by the lung. So it's a protein we all produce. And we have data, which I won't get into lots of detail, but you'll have to trust me on this, that shows that there is dysfunction of SPA in individuals, especially with certain genotypes of SPA2. SPA is made up of two peptides, SPA1 and 2. It looks like this. It looks like a bouquet of flowers. It's a very large protein, octadecamer, and it's made up of these monomers, which are peptides. So they have these different areas or these different segments that are responsible for different function. And we have found out, particularly in this area, the carbohydrate recognition domain, which is responsible for pathogen binding, receptor recognition, that just a one amino acid change in that area really changes the function of the peptide. So much so that it's a problem in patient with asthma, and we've correlated this polymorphism with worse asthma control, increased asthma exacerbations, and low lung function. So we're proposing that replacement of a defective or absent full-length SPA with a peptide of 10 to 20 amino acids can restore the full function of the protein. And so that is some of the work we're doing. In fact, that seems to be the case. We just give the 10 or 20 amino acid peptide. We can deliver it by inhaled formulation and recapitulate all the functions of the intact protein. And so we found that it reduces this airway responsiveness in a mouse model. And then we have also strong evidence to support this protective activity through direct interaction with eosinophils, which are really important cells in allergic asthma. We think that they perpetuate the inflammatory response, and actually we can induce apoptosis with the peptide, which is cell death. We want to get rid of those eosinophils. And we also think the epithelial cell, which lines the lung, which is really important in terms of interacting with pathogens and allergens, that in fact that SPA decreases the exuberant response of the airway epithelium to just modulate inflammation. And so these are just some data from an animal model, so that we use a house dust model of asthma in our laboratory, and this is in mice. And so what we do is we give them, just like you would in a human, you can do a methacholine challenge where you give increased doses of methacholine and look at how twitchy or how responsive the airway is. You can do the same thing in the mouse. And so normally if you give methacholine, what you can see is there's an increased airways resistance as the airways constrict. But if you give the peptide at certain key points, you can see this nice decrease in airways resistance, just with the little 10 amino acid peptide. And we think it's driven by mucin, maybe one of the mechanisms, but there's a whole host of mechanisms around the STAT phosphorylation interleukin 6. When we give the peptide to mice that have been exposed to house dust as a model of asthma, it decreases eosinophils as well as mucin. This is the PAS score. So we were excited about that. These are important outcomes we think about in the airway in patients who have asthma, and we're seeing this change in mice. But of course, we're not mice. So what happens in human cells? So we can culture epithelial cells in the laboratory, and we do bronchoscopy as part of our research, and we culture them at an air-liquid interface so that epithelial cells differentiate. They have cilia and produce mucin. They look a lot like the cells in the lung. And so we expose those cells to a cytokine, interleukin 13, that we know very much increases mucus. This is a mucin protein, MUC5AC. So this is the full-length SPA, and so what you can see is IL-13 really increases, MUC5 very much decreased with the whole protein. And then these are 3 different peptides. You can see whether it's 20 amino acids or 3 versions of the 10 amino acid, a nice attenuation of MUC5. So these are just some examples of where we're going with this. And what we hope to do is actually deliver it in inhaled form. We're writing a small business grant to move this ahead. And so maybe one day I can come back and talk to you about introducing a new therapeutic, a new first-in-class therapeutic for asthma. So this is where sort of the academic life can be very satisfying, because to think that something we've been working on in the lab might actually be a treatment for a patient. Now the bar's high. You know, the likelihood is on the low side that we can make all the milestones, but we're certainly going to give it our best shot. All right, so let's get back to talking about what asthma is. And we talked about how it's a collection of characteristics. It can present early in life, late in life. It's, of course, manifested by symptoms of wheezing, cough, shortness of breath. Exacerbations are really important. That's what many of you will see when taking care of these patients in the hospital or in the outpatient setting. And so what we have found that we looked at different ways of describing asthma, and we realized there's a lot of heterogeneity. It's not all one disease. And if you've taken care of patients who've been on high-dose medications and not responding, you probably have developed an understanding of that. So how can we get to the bottom line? Well, understanding disease mechanisms will really guide therapy to a more personalized approach. And this is really, sort of an overall slide that's being applied to a lot of different areas right now. Certainly cancer, oncology has been doing this for a while, and they're really the leaders in this arena. And so we've been following their lead to try to understand, well, if asthma is not all the same, can we determine what kind of asthma a patient has in clinic, and then devise a treatment plan and give them the best therapy for their asthma? And that's really this whole issue of precision or personalized medicine. And that brings us to this concept of asthma phenotype. So a phenotype is properties of an organism really produced by interactions of the genotype and environment. So these are going to be clinical characteristics. Clinical characteristics, triggers, general inflammatory processes. The issue with phenotype is doesn't suggest an underlying mechanism. That's where the endotype comes in. So it's a pathway that explains that phenotype. So that's what we're really trying to do in asthma is we're trying to link the phenotype with the endotype. Because if we understand what drives it, then we can get to the root cause. And that's where our explosion in terms of immunology knowledge comes in. So this is a busy slide that really goes over the different kinds of asthma we're thinking about these days. I think the take-home message is there's really two buckets. There's type 2, which is going to be your typical sort of allergic eosinophilic inflammation. So that's that eosinophil coming back. And then there's non-type 2. So those are the two buckets. So that's sort of the first branch point. And then under those two buckets, you have different subphenotypes. So the most common is allergic asthma, sort of like our patient that we talked about today, early onset, lots of allergies. Then there's aspirin exacerbated respiratory disease. She also had that because she had nasal polyps. There's also exercise-induced asthma that has its own pathophysiology. Sometimes you can treat it the same way you treat asthma, sometimes not. And then we have this late onset eosinophilic. These are usually women in their 50s presenting later in life with asthma, and it can be a very challenging kind of asthma to treat. Associated with sinusitis, lots of eosinophils, less atopy, less allergy. And then there's a very late onset, even later in 60s and 70s. And then we move over to the non-T2. You know, unfortunately, in our world, obesity, the epidemic is real. It's huge, affecting a lot of health in general, and certainly a lot of different disease processes. Asthma is no exception. So obesity can really produce its own kind of asthma, or it can make allergic asthma worse. So just to keep that in mind. And then on this side, these are the non-eosinophilic type of asthma, like smoking related. About 20 to 30% of asthmatics smoke. And I must tell you, I'm very worried about this whole vaping, sort of movement. I think when vaping first came out, it seemed like a great idea to help patients quit smoking. We're now finding that vaping has some effects on the lung and the heart that are detrimental. So I do feel like the data are out, still, the jury's still out on how safe vaping is. And I worry about, my son's an 18-year-old, he tells me about these kids using these Juuls with these big nicotine doses, concentrations. That type of thing is definitely worries me. Then there's some asthma that has very little inflammation. It's really a smooth muscle problem. And then there's a whole school of research looking at environmental exposures and infectious diseases as causes of asthma. So that just gives you an idea of the heterogeneity of what we've got. What you might have thought was just the simple little asthma, everybody, everyone knows somebody with it, is a little more complicated. And so this slide is just to remind me to tell you that there are multiple endotypes that drive asthma phenotype. So let's look at one. If we look at this one, eosinophilic asthma. So the endotypes could be that allergic asthma that we talked about. There could be aspirin sensitive, there could be severe late onset, and then there could be fungal induced. So there might be more than one endotype driving a phenotype. So that's also adds, I think, an element of challenge as we try to dissect this in the clinic. And of course, I've got two slides these are the busy slides. I'll not spend a whole lot of time, but just to help you appreciate mechanisms, I could spend lots of time on this, but we think about allergens, of course, and we think about irritants and microbes, a lot of interesting work being done with viruses inducing asthma, and certainly even staph in particular. And these are leukotrienes as well, and 5-lipoxygenase. These are two chemicals produced especially in our aspirin-sensitive patients. So that's the eosinophilic side. The non-eosinophilic the focus really these days is more on in particular infections. Mycoplasma pneumoniae is certainly one of them, even gram-positive and some gram-negative bacteria, as well as oxidative stress and air pollution is a big deal. I live in Phoenix, I live in Tucson, but I have a lot of patients from Phoenix where the air quality is very poor. And in the summer, because of ground-level ozone, they can't leave their house because it's a chemical reaction induced by temperature. And Phoenix is number 23 in the country for particulates because of the dust. And so therefore, I see the folks that I see from Phoenix, which are quite a few, have a real problem with the environment. So it's a real issue. So when you see a patient in clinic, and you want to make sure what you're dealing with, you want to make sure that, of course, is this asthma? So you want to confirm the diagnosis, history and physical. You definitely want to do lung function. And I know that's something that isn't always done initially in a general internal medicine clinic, but it's something you want to send your patients to have done. And some clinics will have spirometry. And then, of course, address medication adherence and technique, really important. There's been a lot of million-dollar workups that could have been not done if technique was looked at correctly. You wouldn't believe how often I see and the use of a spacer is really helpful. Then, of course, what's contributing to the asthma? You want to think about comorbid conditions, allergy, sinus disease. Could it be COPD? Have they smoked? How about reflux? Vocal cord dysfunction. I'm going to talk a little bit about that in a minute. Then, if it looks like it's severe asthma, then you're going to want to think about maybe sending your patients to your friendly pulmonologist or allergist, and full pulmonary function tests are often done to look at how big the lungs are, look for air trapping. Methacholine challenge is something to look for that bronchial hyperresponsiveness we were talking about. And then the use of biomarkers and imaging, which I'll talk about a little bit more. And then what would an asthma center add? I think what we do in an asthma specialty center is we can do additional workup for phenotyping comorbidities. We have trials available for patients. And of course, we use a lot of the biologics, which I realize our allergy and pulmonary colleagues do that as well. So speaking of comorbid conditions, I spend a lot of my time thinking about this because if one can treat these areas well or these disease processes well, oftentimes the asthma itself does much better, and patients need a lot less medication. So we think about our patient, of course, had sinusitis rhinitis and nasal polyps. So you think about that. So you might think about do they need some skin testing? Do they need nasal steroids, saline rinses, etc.? Look for obstructive sleep apnea. That can make asthma worse as well. We think that's through enhanced vagal tone and bronchoconstriction. Vocal cord dysfunction. If you've got somebody who is on high-dose inhaled steroids, maybe high-dose Advair, Dulera, etc., not doing well, having voice changes, have neck tightness. We think about upper airway dysfunction. And for that, I think this is a tough one. Sometimes our ENT colleagues can be helpful to look at the upper airway. Sometimes we'll have to do I do a methacholine challenge, and then I'll do direct laryngoscopy to look and see if the airways or the vocal cords are moving paradoxically inward with inspiration instead of out. And we actually treat that with speech therapy, not medicine. Reflux, of course, can be a cause of vocal cord dysfunction and worsening asthma. So we pay a lot of attention to acid and non-acid reflux. And then obesity, as I mentioned. And then this issue of steroid insensitivity, meaning that patients need more steroids than you think they might to get a response. It's like a shift in the dose-response curve. That can be asthma itself or affected by these comorbidities. And so other things, too, you got to think of allergy. Smoking is a big issue. I see a fair amount of asthma-COPD overlap in Tucson. I'm surprised. I think there are patients who had asthma, smoked, and then developed an element of COPD. So they have some reversibility. So they do have some response to inhaled steroids, which is good. But treating these people is a little bit of a mystery. And we're part of the American Lung Association network, and we're writing a protocol on really trying to determine a treatment plan for these patients. Think about alternative diagnoses. I think one of my 2 cures of asthma is when one of my patients came in, I could hear him wheezing across the room. He needed a new mitral valve. So we got him a new mitral valve. Asthma's cured. The second cure was when the cat died. Oh my, cat died. So most patients don't want to get rid of their pets, but the cat left, and amazingly, the asthma did much better. Anxiety and depression certainly runs in these circles. Non-adherence we talked about, and then, of course, the drugs I mentioned before, aspirin and nonsteroidals. All right, so what can we do in the clinic to figure out what kind of asthma a patient has? Well, there are these entities or biomarkers that help us define what kind of phenotype does our patient have. And so there's a list of them here. The truth is, what most of us are using are blood eosinophils right now. Some of us will use this exhaled nitric oxide. As you remember, our patient had an exhaled NO of 40 parts per billion, suggesting untreated inflammation, and more of the type 2, the eosinophilic, so that's helpful. My lab will do sputum eosinophils, but that's pretty tough. It's not really a clinically applicable test right now. IgE is something you might consider in the setting of allergy, really if you're thinking about a biologic. Total IgE, yes, there's some correlation with severity of asthma, but so it can be helpful to define allergy, but you want to do either allergy skin testing or allergen-specific IgE via blood testing. These 2 biomarkers here used to be all the rage, but they're sort of fallen out of favor. They're IL-13 driven, so not so much. And I'm going to tell you about 2 new ones that are in development that I think are pretty interesting. CC16, which is club cell secretory protein 16, and eosinophil peroxidase. So eosinophil peroxidase is a granule. It's a product of activated eosinophils. So the group at Mayo Scottsdale is developing this as a point-of-care biomarker through nasal swab and throat swab. So what I think is cool about this is they have some small studies showing that it correlates, that EPX measured by in the nose or by throat swab correlates very nicely with blood and sputum eosinophils. So why does that matter? Well, think about it. If you could know in the clinic right then what your patient's eosinophil state is, that would really be helpful, as you'll see, because it'll help you decide on treatments. It'll help you decide if they're steroid responsive, if they've got EOS, and in fact, you don't have to wait for the blood eosinophils to come back. And if you're a pediatrician, much easier than drawing blood in kids. So we're going to be validating this in our clinical trials network that I'll tell you a little bit about at the end of my talk, and I'm excited about this. So you might be seeing this. CC16 used to be called Claricell, now it's club cell secretory protein. It has some protective effects against noxious exposures in the setting of obstructive disease. Serum levels are reduced in smokers. There's cross-sectional associations in asthma and COPD, and it's being investigated in longitudinal studies. And how I became interested in this was the group, my colleagues at Arizona, Fernando Martinez and Stefano Guerra, published an interesting trial. We have a children's respiratory study where kids have been seen really since the 70s, since they were very young, and there's a giant repository of lots of different samples, demographics, lung function. So they went back and looked at blood levels of CC16 and found that if you had low levels at age 6, it predicted low lung function later in life. So what did that low lung function look like? Well, it could be asthma if you had allergies, family history. It could be COPD if you smoked. If you didn't have either, you might just have reduced lung function for your age. So that got us thinking, what is the relevance of this? And so we explored the gene that controls the levels of CC16 in a cohort from the Severe Asthma Research Program. So these are the gene, actually it's the messenger RNA levels that we were able to obtain from a group of patients with severe asthma that underwent bronchoscopy. So they underwent bronchoscopy and their little epithelial cells were brushed, and then the RNA was extracted, and we were able to look at the gene, the mRNA, that controlled levels. And this is directly from the airway. And we found some really, I thought, exciting results. Basically, the lower your level of CC16 gene expression, the lower lung function you had, and the more likely you were to go to an emergency department or need oral steroids. So this is now, we presented this at ATS last year. This is turning into a whole research program trying to understand exactly what it does. But certainly, if you have this SNP and your levels are low, you are at risk for lower lung function later. And exactly what it does is we're looking at this in mouse models as well as in our human cells. So how do we put this all together when we see a patient with asthma? I'm going to take you through this complicated slide. So if you see a patient whose asthma is not doing well, so let's say they're having a lot of exacerbations, a lot of symptoms, they're waking up at night, and they're already on, are they on inhaled steroids and a long-acting beta agonist? So first you want to do that. Make sure that they're taking it, that they're using the appropriate technique, and are they getting better? So if they're getting better, then the asthma is uncontrolled. No, then you just need close follow-up, especially if they've been poorly controlled and they're doing better. If they, unfortunately, have poor symptom control, they need a couple of bursts of steroids a year, or hospitalization, or their lung function is reduced, then you have a situation where you have an uncontrolled patient on high-dose inhaled steroids. And at that point, that's where the branch point happens. So if that's true, you might consider adding on another medication. This is Spiriva, tiotropium. We use that a lot in COPD, but you can add it in asthma. It actually is shown to be beneficial. You could think about Singulair, we talked about with the patients with the nasal polyps. Even theophylline is still around. This is sort of an ancient history drug, but some patients do well with it. You might consider a macrolide antibiotic, like azithromycin, has been shown to have some benefit. A couple of recent trials. So you want to add on a non-biologic therapy and assess response. And usually assess response, and probably you want to give patients a few months to really evaluate their response. But you see them about every 6 weeks or so. If they're still uncontrolled, then you're going to think about a biologic and this phenotyping. And so you want to think about, do they have eosinophils or not? Can you get a measure of exhaled nitric oxide? Can you figure out what kind of asthma they have? And for this, oftentimes, it does require some help from your friendly pulmonologist or allergist. So these are the treatments approved, and this I'm not going to go into a lot of detail, but I'll show you a little bit about what's out there so you've heard the names, because my thought is, yes, a lot of specialists will use these biologics, but it's creeping down into general internal medicine too. So the point of my talk today is just to make you aware that these exist, and when you might think about them, when you might want to refer, get some help from your specialist, and co-manage these patients. I love it when my primary care colleagues would like to co-manage these folks with me. And so you can appreciate what the point of this slide is. Everything in red is approved. So a lot of action in the T2 or type 2 asthma, the eosinophilic asthma. The ones in blue are under development. So a lot of action going on right here, and I'll talk a little bit about that. So omalizumab is Xolair, so you've heard the name. So what it does is it binds to IgE and takes it out of circulation. IgE is the antibody we associate with allergy. It can bind to cells and hold on to allergen and cause cell degranulation and all the symptoms of allergy, the runny nose, watery eyes, and wheezing in the case of asthma, cough, shortness of breath. And so what the data shows, if you've got eosinophils or a slightly elevated exhaled nitric oxide, you tend to be a responder to Xolair. It's been around for about 10 years. It was actually 15 now. It's one of our first biologics. And so what some analyses has shown is if your nitric oxide is elevated or your eosinophils are up, you can decrease asthma exacerbations very nicely. Periostin is, again, an older biomarker we don't use a whole lot anymore. So Xolair was the first biologic, and I think it really gave us an idea that we could target that IgE, and that's because we've learned so much about the immunology. Now we have an example of how it translates to therapy. So that's exciting, but it didn't quite do the job for everybody. So now we have biologics that are directed against interleukin-5. So why do we care about interleukin-5? It actually keeps eosinophils alive. It enhances eosinophil survival, and it has a lot of effects on the lung, especially on the airway epithelium. So we love to take IL-5 out of the airway if we can, and now we have 3 drugs out that do that. And the key thing is, if your patient has very high peripheral eosinophils, now 150 is on the low side, but if they're greater than 300 in the setting of asthma, they're already on high-dose inhaled steroids, that's when you might think of an anti-IL-5. And we have 3 choices. There are a lot of mepolizumab Nucala, an IV form called Syncair, and benralizumab Fasenra. So I don't expect you to remember any of these, just that they exist. And then, in fact, if you've got lots of eosinophils and you've noticed that in your patient, this would be something to think about or talk with your allergist or pulmonologist about. The one that's just recently approved is called dupilumab, and so it actually binds to 2 cytokines, interleukin-4 and 13. And this one's nice because you don't have to have high eosinophils for that, and it has really had some very nice data in terms of patients who are very poorly controlled. If they have eosinophils, the data are a little more compelling, but it really has effects on mucus in the airway, as I showed you earlier, and the eosinophil. So it'll be interesting to see where this goes. So a lot of action in the allergic asthma or eosinophilic asthma space. In the non-T2 options, again, these are people with lower eosinophils, don't have a lot of allergic inflammation. We have a few choices, but you can see there's a lot of things under construction, but Spiriva would be an option, perhaps macrolides like an azithromycin, or bronchial thermoplasty. I don't know how much you all know about bronchial thermoplasty. That's a process of actually applying radiofrequency heat to the airways to reduce the smooth muscle. We don't use this as much because there's been a challenge in getting it approved, and we don't really know who the best patients are for that treatment. And so this is the action in the non-T2 space. You can see it doesn't exactly look like the other one, which was all red. So I put thermoplasty in red because it's approved, although hard to get. And there's a lot of things under construction looking at different cytokines, IL-1, IL-6, imatinib is a mast cell inhibitor. So there's some more action, but still the T2, this non-eosinophilic asthma really represents a significant unmet need. So now that we know all this about the immunology, we've translated it to care, what are we going to do with this? And so I wanted just to take a few minutes and tell you about a clinical trials network that I'm part of where we're actually going to put this into action. And so this is a network called PRECISE. It's funded by the NIH, And it just came together in 2017 to conduct innovative proof of concept studies in biomarker-defined adults and adolescents with severe asthma. And there's 10 clinical centers, 1 data coordinating center, and represent really the centers in pediatric and adult asthma. And these are the centers that you see. We've got UCSF, UCSD, Denver, Chicago, and this is the Great Lakes Partnership, Cleveland, Boston. We have NHLBI, of course, and UNC Chapel Hill is the data coordinating center, Pittsburgh, Johns Hopkins, WashU, and then, of course, Arizona. And we're in partnership with Wake Forest. So what are we doing? Well, we're going to identify novel therapies because the truth is the biologics that I showed you work for some of the patients, but not all of them. I mentioned to you that the non-eosinophilic group represents a real unmet need. And so how do we devise therapies or try therapies for that group in particular? And even those folks, like I have lots of folks on biologics that are not completely controlled. So we haven't quite cured or at least completely controlled asthma. We have work to do. So the objective would be to identify novel therapies in biomarker-defined groups and then optimize the subgroups targeted for treatment by refining the biomarkers and definitions during the trial. So a patient would come in and be phenotyped, as I mentioned, with the biomarkers we talked about, and they would be able to have up to 3 different therapies in a trial. So they would go through a first treatment phase, and depending on if they did well or did poorly, they could stay. If they didn't do well on it, they would come off and move to the next treatment. So it's called an adaptive design. And like I mentioned, the oncology folks have been doing this for a while, so this is brand new to respiratory. And I'm hoping that we can be a blueprint for other chronic, for the treatment and for the trial design for other chronic diseases as well. And then we hope to actually validate some biomarkers, like the EPX that I told you about, and then explore the safety and effectiveness of therapies in pediatric asthmatic subjects. So these are the interventions we've proposed. They're going to be a little out there. So imatinib is a KIT inhibitor that reduces mast cells in T2 low patients, so non-eosinophilic patients. JAK inhibitor reduces signaling through type 2 cytokines. And you'll notice that the JAK inhibitor we use for other diseases in the arthritis world, in the autoimmune world. We're moving it over to asthma. Bronchovoxome is a bacterial lysate that we think actually changes the microbiome and reduces eosinophilic inflammation. Cavasonstat is a GSNO reductase, which is made by the epithelium, and it actually, we think, can increase bronchodilator response for some effects on the beta-2 receptor. Medium-chain triglyceride, it's a food additive, altering the metabolic regulation of T cells. And then the last one is an anti-IL-6, which is definitely used in rheumatoid arthritis, and we're moving it to asthma in those folks who have high IL-6 levels. So these are very different, we know, and we're excited to be able to try them in this setting. So the idea is there's a master protocol and shared infrastructure, central systems, central governance, common protocol elements, and there's efficient use of patients through a central biomarker screening. And so we try to enrich the population, meaning if a patient comes in and they have, let's say they have eosinophils, they have a high IL-6 level, then they may be eligible for a couple of different interventions, for the IL-6 inhibitor, for the JAK-STAT, or for the bronchovoxome. So we try to enrich the groups that will receive certain interventions and allow patients to receive more than one, maximizing the amount of information with a moderately sized sample, so you don't need millions and millions of patients. So it's called an adaptive platform design. So the trial begins with interventions available, and other interventions enter as they become available. So we're looking at 6 novel interventions, and it includes, and what the key thing is we also do what's called a futility analysis. So after patients go through and really nobody's responding to a certain intervention, we can actually take that out and bring something else in. So I'm leading a committee that has the next interventions in line should any of these not be effective. Because and then patients can circulate back into the trial. So these biomarkers are determined at the initial screening, and they're classified as either biomarker positive or negative for each intervention based on profiles. And then treatment assignments are then determined so that the subgroup targeted are likely to receive that intervention. So if you're high eosinophil, you're going to get the JAK-STAT or the bronchovoxome, for instance. If you're low, you're probably going to get the imatinib. And then as data accumulate, what's beautiful about this is the data are analyzed real time so that we get a better understanding of who responds to what as the trial's going on, and then we can change the criteria for which new patients come in. So it's continually adapting. And then the treatment assigned probabilities reflect subgroup refinements. So we're going to look at 600 adults and 200 adolescents. And so this is sort of the overall design. So patients go through a screening phase. They get their biomarkers to assess sort of what kind of asthma they have. And then they're going to be randomized based on some a priori criteria. And they'll be offered certain interventions depending on their biomarkers, clinical history, and physiology. And then they'll either get the drug or placebo. There's actually about of the 6 interventions, there's only a chance to get placebo twice. So patients can have up to a minimum of 4 active treatments. We thought that was really important because you wouldn't want to have to go through and get placebo throughout all the study. So then they'll go through a treatment phase for about 16 weeks or placebo, then they'll do the washout, and then they can get re-randomized to the next treatment. So the study duration is 42 months. Again, we hope to look at 800 patients in 30 months. Treatment assignments made through 36, and participants, depending on when they enter the study. If you come in the beginning, you'll get up to 6. If you come in towards the end, you may be eligible for less. And then 25% of the patients receive a second placebo. So 75% only receive 1 placebo. So we thought that was actually a nice aspect of the trial. Because I do trials, and sometimes it's tough because you want to try a new biologic, but then there's an equal chance that one could get placebo, and patients, you can imagine, aren't as excited about that. And like I mentioned, there's a way of doing a futility analysis to stop a test treatment early. The futility, the outcomes are really about exacerbations, lung function, and asthma control. So they're very clinical outcomes. Do these interventions help these 3 important outcomes? That's what we want to determine. And then we can adapt the sample size. And so the final analysis really talks about lung function, symptoms, and exacerbation. And then the final efficacy analysis conducted for the target group only. And then this precision analysis is really, we're going to look at patients who we think would be responders and folks we think might not be, because you got to compare them. And then we'll have our placebo. So I wanted to explain this to you because I think it's a really innovative study design that's not being used outside of oncology a whole lot. And so I'm just excited that we have an opportunity. It's taken us a while this is work I'm summarizing now, has taken over a year, multiple meetings in Washington, D.C. to hash through all of these issues. But I feel like we're getting there. So I know I've conveyed a lot of information over the last 45 minutes or so. Would be happy to talk about questions if you've got particular patients that you're worried about or anything about the immunology that I mentioned. But the take-home message really is I think our understanding of the biology of asthma has really improved dramatically. I think that that has allowed us to translate that understanding to treatments. And so that's really exciting. We can target certain inflammatory pathways that we really weren't able to do before. Steroids, as you know, is like a big sledgehammer. It takes out the inflammation for most of our patients, not everybody. The problem is there are a lot of side effects. And we don't want to keep patients on long-term steroids because there are eye issues, bone, weight gain, skin changes, diabetes, huge issues with long-term steroid use. So these biologics have really allowed us to really move and really help patients come off steroids or lower their inhaled steroid dose, because even high-dose inhaled steroids have side effects over time. So I hope I've conveyed asthma is complicated. There's airway structural changes and intersecting with early life events, genetics, and of course the comorbid conditions. I think if you see these patients in a general internal medicine clinic or a specialty clinic, the key thing is really focusing on those comorbid conditions as you think about the asthma critical. And I think as we understand this heterogeneity and we can have more tools in the clinic to figure out what kind of asthma a patient has, then that will then trickle down from specialty to general internal medicine, primary care. And I think it's really going to allow us to personalize therapy much more than we ever were able to before. So thank you very much for your attention.
you say just 2 minutes about the food additive that y'all are trying?
Oh, sure. The medium chain triglyceride. So it actually is a metabolic food additive made by Nestle, and it was actually touted first as a weight loss supplement, but it turns out it has effects on mitochondrial function, which then have really downstream effects on T cells. And the T cell is a key cell in asthma, especially the CD4 cell, because it's one of we call them the captains of the ship in terms of the T2 asthma for sure, the type 2 or eosinophilic asthma, really setting the stage for certain mediators being produced, like you heard me mention IL-13, IL-4, IL-5, and so we think that this additive can actually modulate T cell function. And we found that, and this is work done at Cleveland, so Sirpal Ezram and her group has really been moving this forward. So there's a weight loss aspect to it, and then in folks who have elevated exhaled nitric oxide in particular seem to be the folks that respond to it. So again, thinking about this untreated T2 or eosinophilic inflammation. So it's kind of, I think it's cool. I wouldn't mind getting my hands on some of that stuff.
Have you eat it or?
Yeah, you put it in your coffee, or you can make a milkshake. Mm-hmm. Yeah.
I'm ready.
Exactly. That's what I told her. I said, send me a few packets. Yeah.
Regarding the connection with obesity,
Yeah.
Louisiana, we have a lot of good food, we have a lot of people
Absolutely,
that are
you
a little
do.
too heavy. So is there a certain threshold that people can lose before you might see improvement rather than just coming to, say, a normal weight? And
Right.
also, do you ever use procedures, banding, or weight loss surgery? Because I've seen that sometimes also gives
Right.
improvement.
Great
But
question.
How do you select for those people?
Absolutely. Great question. Obesity, having moved from North Carolina and then now in Tucson, a big issue all across the country, I think. And so what we know, Ann Dixon at the University of Vermont has done some very elegant work on obesity and asthma. And what she's shown is that folks who have like allergic asthma and then become obese, the obesity can make it worse, but bariatric surgery tends to be less effective for those patients, although it's helpful, whether it be banding, more involved procedures. The folks who develop asthma late in life and are obese, that tends to be a little different pathophys, an IL-6 really driven disease. That's one of the reasons we chose an anti-IL-6 intervention. So that still remains to be seen, whether that's going to be recommended. But certainly those patients would do well. They tend to do better with bariatric surgery. And I've seen asthma and reflux and sleep apnea and sinus disease all get much, much better with weight loss. And generally in these folks, if getting the BMI below 30 is really the key. That's sort of at 30 we start to sort of see things happen. But usually we're looking at bariatric surgery for folks in the BMI's 35 to 40 range. So even the difference between 40 and 30 is huge. It's a lot of weight. And you will see some very significant changes of the asthma and the comorbid conditions in that group. So I am a big fan of bariatric surgery, especially for if there's a large amount of weight to lose. One of the challenges we have in Tucson is just patients have to be on a diet for 6 months first, is usually what the insurance mandates, and just trying to get it all covered. But if they're willing to stick with it, it can be a great thing. Yes?
From the pediatric side, so if you don't have pheno, is there any good surrogate marker like peripheral eosinophil or IgE?
Yeah, peripheral EOs are good. It's just you'd have to send them for a blood draw, which kids don't. Nobody's a big fan of getting their blood drawn, but sometimes it's tougher in kids. But no, peripheral EOs are fine, absolutely, and can be are a very good surrogate. I think I'm more of a fan of the Airway because I think the Airway eosinophil state is more indicative, and there are correlations with peripheral blood. They're just not super strong, but it's the best we've got. So that's why I'm excited about this EPX marker, because I think that really reflects airway eosinophils. And I think now that the group, the Precise Network has voted to measure EPX in all 800 patients. So we're going to have a really nice opportunity to validate that. Because the studies that the Mayo Group did, they're pretty small. And so that was the downside. So that's why I'm excited about it.
I have one more question.
Yeah.
Like, in very uncontrolled asthmatics, what is the chance of them having pulmonary eosinophilia or eosinophilic syndromes? When we have to investigate for that?
Yes, that's always something to think about. If you've got a patient with asthma and high eosinophils, is it just allergic or eosinophilic asthma, or are we moving down the lines of allergic bronchopulmonary aspergillosis, which is more of a fungal hypersensitivity state, or what we used to call Churg-Strauss eosinophilic granulomatosis with polyangiitis, long term. It used to be called Churg-Strauss, which is more of a vasculitis. And so I think if the eosinophils are, and then there's eosinophilic pneumonia. So there's a whole differential in terms of the eosinophilic state. Usually you won't see infiltrates so much with eosinophilic asthma. You should not. If you start to see infiltrates in the lung, it's sort of a time to think about mucus impaction, fungal hypersensitivity. You actually can measure an IgE specific for aspergillus. And that just means that the asthma is going to be tougher to control and may require oral steroids or antifungals. But then if you're thinking vasculitis, and you're going to want to check ANCA, C-ANCA, P-ANCA, and that's a whole different ball of wax. If those are positive, then you're going to want to work with your rheumatology colleagues really along those lines. And then eosinophilic pneumonia will be peripheral infiltrates, could be acute or chronic. Oftentimes there's an exposure, and that often requires bronchoalveolar lavage, bronchoscopy to sort that out. But that's a very different sort of picture compared to regular old asthma. Yes, sir?
It's great to have these biological agents, at least 1 or 2 every year coming up. Very expensive.
Very.
And the concern is that once a drug is approved, any doctor can prescribe it.
Right.
And the patients are liking because it is very expensive, and they make the doctor spend a lot of time to approve it. And this makes the patients holding tight on it. They wanted it. In the meantime, as you mentioned, the comorbid conditions are not controlled at all.
Right.
They have the cat, and they have the smoking, they have the obesity, and dust mite, and all this. And this makes the insurance companies are more tight in approving it for us. Then I have a question. The Meneely-George has been now for more than 25 years. It's being used indiscriminately, particularly in children.
Right.
Why there is no test for the urinary leukotriene E4?
Good question. So your comment about the biologics, I think you're absolutely right. One of the things we're trying to do in Tucson is really we interact well with our allergy and pulmonary colleagues, and so we have get-togethers and talk about difficult cases. We talk about what we offer at the university in terms of our sort of comprehensive evaluation, phenotype evaluation. Our allergy colleagues, because they have been doing immunotherapy and other biologics for a while, are much more comfortable, I think, using them in their practice. But they still send them over to us. The pulmonary folks, it takes infrastructure because you've got to be able to give injections, and some pulmonary practices aren't really set up for that. So then they're sending them our way. So we try to have a good symbiotic sort of relationship because I don't want that to happen. Because I've had some referrals where patients are on a biologic and there's so much other work to do before they even needed it. Because we go through the whole protocol and really make sure we've tried our best with all those comorbid conditions. You're totally right. Meneely-George, we measure urinary LTE4 in the lab. And I don't know why it's not a commercially available test. It should be. And the Meneely-George studies from way back when, the dose is on the low side to really inhibit leukotrienes, but it had the lowest side effect profile. So I feel like it can, especially in the folks who have the nasal polyps, can be effective. But I still am using xylutone in some of these patients because I think it's a more effective inhibitor of the leukotrienes. So xylutone or Zyflo was approved in the 90s, but then the marketing, Meneely-George just stomped all over it when it came out because it was a once-a-day pill and it was easy, and the side effect profile was less. But I think xylutone is a much more effective inhibitor because it works higher up on the pathway. But it's harder to get, so you have to work harder to get it. So I don't know why these aren't clinically available tests. They should be. All right. Thank you very much.